my colleague and dear friend, Dr. Banu Arun, who is a professor of medical oncology in MD Anderson Cancer Center. She's also the director of medical genetics clinic in MD Anderson. I selected 4 cases today, and we will see how it is going to go with the discussions and questions. We don't need to finish all 4 cases, and we would like to make this session as very informative since we have Dr. Arun with us. So if you have any questions in each points of the case, we can stop and ask questions. Again, Dr. Arun, thank you very much for joining us. So we're going to start with case number 1. It is a 31-year-old premenopausal female. She doesn't have any significant previous medical history, and she has this palpable right breast mass. And this is her mammogram showing the lesion here, and it was a breast mass. Somehow it is cut here. Can we readjust because the slide is not like this? Can we adjust this over here so we can see it? So her breast mass was 1.4 centimeter, and it was associated with microcalcifications, and she had an additional area calcifications away from the main mass. And her physical examination, also ultrasound evaluation, revealed that she has additional lesions in between. So it was considered that she has a multifocal multicentric disease, and she had a single suspicious lymph node, and FNA was performed. In addition to corneal biopsy of her breast lesion. So this is her corneal biopsy showing this diffusely infiltrative lesion. High magnification showing that it's a poorly differentiated carcinoma with marked pleomorphism, and then there were definite areas of where there was an increased stromal lymphocytes. And first, what is the diagnosis? And we have the audience response system. I think everybody has clicker. Have you distributed clickers yet? So we're not distributing? Okay, sorry. So we're just going to use our hands. And so what is the diagnosis? Invasive breast carcinoma, NOS, invasive carcinoma with medullary features, invasive carcinoma with lymphocyte predominant type, invasive breast carcinoma rich with tumor infiltrating lymphocytes. So who votes for 1? Okay, I'm the only one who voted for 1. Okay. Number 2, invasive carcinoma with medullary features. Okay. So, lymphocyte predominant type or rich with TILs? Who votes for 3? 1 person. Who votes for 4? So, majority of the people vote for 4. It's appropriate thing. So, we made the diagnosis of invasive ductal carcinoma, grade 3, and then we put in a comment that there's based on histology, there's a stromal lymphocytic infiltrate. Tumor was negative for ER and PR, and her tumor is negative. Her final aspiration showed metastatic carcinoma. So based on this, Dr. Arun, it's a stage 2B multicentric disease with N1 lymph node positivity. So this is her clinical history. She does not have any pertinent family history, and she had genetic testing done before she came to MD Anderson, and no detectable mutations were identified. Question for you, Dr. Arun. When we say genetic testing done in breast carcinoma, what do we mean? Is this all these different genes are included in all panels? In the past, we were always thinking BRCA1 and BRCA2 as the main genes that were associated. What are the significance of these new genes now we have in these new panels?
Thank you for the case. I think this is a very interesting case, also from the genetics point of view. So it's actually a very good question. What do we understand when we say genetic testing? Sometimes when we ask patients, did you have genetic testing, they really think we are talking about the HER2 FISH testing of the tumor. So sometimes they say, yes, I had it. So usually we say, did you have genetic testing for hereditary cancers, familial cancers? Then they know that the test is really, from the blood and lymphocytes and looking at germline mutations. This test was appropriately ordered in this patient, and as Dr. Sahin pointed out, until several years ago, we would only understand BRCA1 and 2, germline genetic testing, then we would say genetic testing. But with the development of the panels, we are also now seeing results where many other hereditary breast cancer genes were tested. In this patient, for example, because she's 31, of course BRCA1 and BRCA2 and then P53 should definitely be tested because any age, any patient with breast cancer diagnosed before age 35, we also check for Li-Fraumeni syndrome for P53 testing. Whether you would choose this panel is more breast cancer related, moderate to high panel, so we have ATM, we have CHEK2, PULPy2, but the genetic testing companies, as you might be aware, are now offering panels where you have up to 28 genes. Some companies even offer panels with up to 48, 49, even 50 genes. Now, whether you need all of the other tumor genes, it's debatable. I think ideally you should look at the family history and not order beyond what is indicated. If this patient does not have any other family history, then we are really ordering the testing based on her age of diagnosis, which is 31. So this limited panel of 5 or 7 genes is actually a very appropriate choice.
All her other staging workup was negative, and based on her stage and based on her lymph node positivity, it was decided that she was going to go on neoadjuvant chemotherapy. So this is what she has been recommended. So the question for you, Dr. Arun, when we say it's a high-grade tumor and rich with tumor-infiltrating lymphocytes, does this make any difference for you? And based on that, do you change your chemotherapy recommendation, or do you even read the comment?
I read the comment.
Okay, that's good.
Anything Dr. Sahin writes, I read it again.
Okay.
So that is a very good question. I think we are in the era where so much information is coming in, molecular testing, detailed description, for example, with tumor-infiltrating lymphocytes. However, I think we have to differentiate our clinical decision with our academic excitement. And in this case, for example, we would offer the patient, regardless of whether there's a presence of tumor-infiltrating lymphocytes or some other, markers beyond ER, PR, HER2 grade, and Ki67. In some cases, as you know, some individuals don't even look at that. But in this patient, the indication for neoadjuvant chemotherapy and then the chemotherapy choice with anthracyclines and taxanes would not change based on TILs.
Okay, thank you. So she had a neoadjuvant chemotherapy, and after her chemotherapy, she had a mammogram where she had the stable calcifications, but the mass responded really well, so there was no residual mass, and her axillary lymph node also disappeared. And with the ultrasound, what we did is we put biopsy clip where we did the axillary FNA, so that lymph node also decreased in size. So in terms of surgery recommendations at this point, there are multiple options. It ranges from total mastectomy with axillary lymph node dissection, segmental mastectomy with axillary lymph node dissection, sentinel lymph node segmental mastectomy with targeted axillary dissection. This is the procedure that we are doing right now in MD Anderson. It's a new procedure, so I would like to discuss this a little. Question for you, Dr. Arun. If she had one of the BRCA1 genes positive, would this affect the type of the mastectomy that you are offering to the patient?
So that is another very good question. It would not, because having a BRCA mutation tells you the risk of contralateral breast cancer risk. So, for example, doing a double mastectomy is an optional procedure. It does not tell us what to do in regards to the tumor treatment surgery, so the surgery in regards to the tumor. So in women with BRCA1 or 2 or other mutations, these choices for the tumor surgery remains the same. However, especially in the United States, what we are seeing is if this patient would have been found to have a BRCA mutation, many, more than 50, close to actually at our institution, 80% of patients elect to undergo double mastectomies. But it's not necessary. That is an elective decision. The choice for tumor-related surgery is not different from this.
So what actually, since she had a positive lymph node before neoadjuvant chemotherapy, the standard of care is that the patient undergoes complete axillary lymph node dissection. So that is what is the standard. But now there is a new trend for doing less surgery for selected patients, especially patients like her, where there is a good response in the lymph node, clinical and imaging response at the lymph node, which was originally positive. So that is the procedure, we call it targeted axillary dissection. And what it is that we put a clip into the lymph node, which was FN8, and then right before she goes on surgery, we put a radioactive seed next to the clip, indicating that this node, which was originally positive, it is going to be removed. In addition to that, we perform sentinel lymph node procedure. Sentinel lymph node procedure prior to chemotherapy is a very sensitive and specific technique, but doing sentinel lymph node after chemotherapy, in some hands it lowers the sensitivity of the procedure, but when we are doing this combined clip lymph node and sentinel lymph node procedure, we have a very high sensitivity and specificity. So this is her segmental resection, which shows the fibrous tumor bed. We identify the fibrous tumor bed with these areas of fibrosis in the breast parenchyma and lack of lobules, so it's a lobular atrophy. And also we have this histiocytic and infiltrate where tumor used to be. So we examine this area extensively. There is no residual invasive carcinoma. We usually sample these areas very extensively, and here again fibrous tumor bed with vascular proliferation, and the fibrous areas extends into the lobular units, and there was a small focus of residual ductal carcinoma in situ. Again, high-grade lesion after chemotherapy, but this was the only residual tumor. So the final pathology report read as residual ductal carcinoma in situ, focal, negative margins, and with her targeted axillary dissection 4 lymph nodes were excised. 3 of them were sentinel lymph nodes. 1 was the clip lymph node. All of them were negative. There was no residual tumor. So based on this, what is her post-op classification of response to neoadjuvant chemotherapy? So her tumor is now TIS and 0. So do we call this complete pathologic response or partial response? Who says 1? Who says 2? Partial response. Because she has residual DCIS. This is a controversial area. In MD Anderson, we would classify this patient as complete pathologic response, because the definition of complete pathologic response based on International Neoadjuvant Chemotherapy Pathology Group and based on many studies that we have in MD Anderson is the lack of any invasive carcinoma in the breast and lack of any tumor in the axillary lymph nodes. So presence of residual DCIS does not change that. There are 2 small studies, one from the United States, one from Europe, show that presence of residual DCIS inversely affect outcome, prognosis, but they are very small studies, and all the other studies indicate that presence of residual DCIS does not affect the outcome. So at this point, we are classifying residual DCIS as complete pathologic response. So based on this, patient is enrolled to this trial, which I would like to describe this trial because as I understand now it is also going to have a very similar trial in Europe. I don't know if it's going to be open here or not, but this is a trial for patients with clinical T1, T3, and 1-0 patients, just like our patient, who receive neoadjuvant chemotherapy, and after they have breast conserving surgery or mastectomy with sentinel lymph node surgery, we evaluate the sentinel lymph node in frozen section. And based on the sentinel lymph node results, patients are randomized during the surgery, either receiving a complete axillary lymph node dissection or no further surgery. So a lot of people always come and ask me if they say, well, do you do a frozen section on your sentinel lymph nodes? In most of the cases, we do not do frozen section, but this trial now is becoming very popular in the United States, and we will do the frozen section of sentinel lymph node if the patient is on this trial, because randomization of the patient is going to be done during the surgery, and then we would do frozen section. I mentioned about this targeted axillary dissection. This is another patient. So here is the tumor, and then here is the lymph node. So these clip lymph nodes are localized with radioactive seed, and the radioactive seed that we extensively use now for our localization of either positive lymph nodes or in the biopsy clips in the mastectomy specimen. It is a very easy technique for the surgeons to localize the area. So instead of trying to put the needles in the biopsy area, we use these radioactive seeds. In terms of radioactivity, it's very minimal risk because all these seeds are now manufactured with a very safe seals. Our segmental resection size became a lot smaller with the use of these radioactive seed localization. And in terms of our sentinel lymph node false negative rate, with using this targeted axillary dissection became so low compared to in the past our false negative rate was around 9% after neoadjuvant chemotherapy. Now it is less than 2%. Any questions on this? Any comments?
No, just I want to ask about the percentage of lymphocytes which I can detect it to evaluate the tumor as lymphocytic type desert blood or it is medullary-like desert blood. Is there any percentage of lymphocytes, stroma, and
as we discussed earlier today, the definition varies from different groups. There isn't really one definitive definition, but most people use more than 50 to 60% of stromal TILs to define the lymphocyte predominance breast cancer. Any other questions? Okay, then we're going to move to case number 2. Case number 2 is a 38-year-old premenopausal female. Again, she doesn't have any significant previous medical history, and she presented with a nipple discharge. And this is her mammogram showing areas of calcifications. Again, multicentric disease, 2 separate sides. And she had stereotactic core biopsies of these areas, and this is one of the biopsies showing a high-grade ductal carcinoma in situ with some periductal fibrosis and inflammation, and higher magnification showing the DCIS, and DCIS was associated with microcalcifications. And based on her breast size, the surgeon thought they can do segmental resection, including those 2 separate areas of DCIS. So she had a segmental resection, bracketing these 2 separate areas with 3 seeds. And since she had a large pendulous breast, the plastic surgeon was involved, and they did an oncoplastic surgery where the lesion, after it is removed, breast parenchyma is turned around, so the shape of the breast could be saved. And one of the main problems about oncoplastic reconstruction is the margin evaluation, and going back to the positive margin is extremely difficult and technically very challenging. So many of our surgeons require intraoperative evaluation of these segmental resections, because if we can clear the margins during surgery, that is the best time, because after oncoplastic surgery, they need to go back and take a lot more sections. So we received a segmental resection, and we utilized intraoperative specimen X-ray for that. And with the help of our radiologist, who not only localizes the seed, but this is the radioactive seed and this is the clip, and they also indicate where the microcalcifications are coming close to the margins. And here the radiologist thought that the area which looks like microcalcification could be ink of the specimen, because a lot of the inks that we use also has some metal particles. So on specimen X-ray, they mimic calcification. So in this one, the radiologist thought the lesion is close over here, and we recommended that the surgeon took additional margin. But over here, they thought, the radiologist thought that it was specimen ink, not a positive margin. So when we gross our cases, we use our specimen X-ray as a map for our sections. So, especially where the areas that we are concerned, we take multiple sections, and then when we look at our slides, we always come back to the specimen map and then correlate with the specimen X-ray appearance. And when we try to calculate the size of the residual tumor, we use this map. And here is the histologic section. Large, even in this low magnification, you can see that the lobular units and ducts are expanded by the proliferation. And again, this ink gets into the tissue like this. Unless you have a specimen map and you look at how the section is taking, sometimes this can create a problem. Tissue, the ink going inside the tissue, obviously you would not consider this as a margin. Here again, area of DCIS, and this is another margin. It is coming close, but it is not right at the ink margin. So this is the high magnification of the first slide. Like here, ink is getting inside the tissue, so this would not consider a true margin. But in this case, there was another margin where DCIS was getting really close, and a higher magnification, again, it is close. This was less than a millimeter. And here we would say this is a transected margin for this DCIS. So ductal carcinoma in situ involving here, and here is the ink. But this is a very focal area. Here is the area. Very focal DCIS present at ink margin. So we said this is a DCIS and extends to superior posterior margin, and based on this, what is the recommendation? So the patient was presented at the multidisciplinary conference. With this case, I would like to discuss this new recommendation for guidelines on margins of breast conserving therapy for ductal carcinoma in situ. So this guideline was published this past year, and just like invasive carcinoma, this is a consensus meeting, and it is based on SSO, ASTRO, and American Society of Clinical Oncology. And they did a meta-analysis of 20 studies, including more than 7,800 patients of DCIS with known margin status. And there were close to 860 patients with ipsilateral tumor recurrence with median follow-up of 78 months. And the median incidence of ipsilateral breast tumor recurrence was 8.3%. So based on all these recommendations, I don't know why the slide is cut here. I think we did not adjust it well, but what the consensus statement indicated that presence of ink on DCIS is associated with a significant increase in ipsilateral breast recurrence, which is not nullified by radiation therapy. So if we have an ink on DCIS, just like invasive carcinoma, we would consider this as a positive margin. The question is, if you have small